Lecture 2 for this week deals with chest radiographs and other imaging in the transport setting. And I cannot apologize enough for getting it to you late. Um, it will not happen again. But this session introduces you to portable chest x ray interpretation and related imaging priorities. The goal is not to turn you into a radiologist, but instead to help you rapidly identify transport relevant findings that change the urgency, the monitoring, the ventilator management, and everything else that has to do with the patient that you are taking care of. As far as learning objectives, we'll be using a structured approach to review portable chest x-rays before and during transport. We'll identify normal landmarks and common technical limitations of transport chest imaging. We'll recognize transport critical findings like pneumothorax, pleural effusion, pulmonary edema, tubes that are in the wrong spot, mediastinum issues, and trauma considerations as well. We'll talk about how the imaging findings affect oxygenation, ventilation strategies, and urgency in ground and air transport. And we'll correlate chest x-ray findings with the patient assessment rather than reading the image in isolation. Chest imaging in transport is really about risk recognition. A portable AP chest x-ray may be imperfect, but it often tells you enough to anticipate deterioration or correct a dangerous problem before you get to your destination. Imaging is just a data point, though. It's not a substitute for assessment. A normal chest film does not cancel distress. A film that looks terrible does not matter until it matches what the patient is actually doing and what you're seeing on assessment. But still, there are several findings that absolutely change the transport planning and should not be ignored. Let's go through a repeatable approach that you can take rather than a memorized list of what different diagnoses look like. That can help to lower the error rates when taking a look at them, especially when you're tired and hurried and stressed. In terms of how to approach reading a portable chest x-ray, the portable AP film is the norm for transports, but it's not the ideal radiology film. Um, it can enlarge the cardiac silhouette. Supine films can hide a pneumo or layer out fluid differently. But you should always read it the same every time. So step one is to confirm the patient, the date, the projection or the type of X-ray. Most are portable AP, usually supine. That can magnify the heart and hide pleural air or fluid. Take a look at the quality for step two. The rotation of it, is it symmetrical? How's the exposure? Does it look kind of like whited out in terms of not the lungs themselves, but the actual film? The inspiratory effort, because it should be held or it should be taken on inspiration, and whether or not the entire chest is visible. Take a look at the what we use as a mnemonic for the ABCDE style. So A for airway, B for breathing or the lungs, C for cardiac, so the mediastinum, the heart silhouette itself, um, D for your diaphragm, and then E is everything else: bones, devices, lines, tubes, anything that shows up on the X-ray. Then step four, always correlate what you see with the vitals, with the breath sounds, with the vent data, with your end tidal CO2 monitoring, and the actual mechanism of the illness or injury. Is it a COPD patient? Is it a pneumonia patient? Is it a motor vehicle accident victim? Things of that nature that can really help to kind of hone in on what you're looking at with the chest X-ray. We'll get to pictures in a minute, but always look for normal landmarks first. So know what the landmarks look like and where they're at on an AP chest film. The trachea should be midline or very slightly deviated. The carina is the key landmark for endotracheal tube placement. Um, Tube placement should typically be 2 to 4 or 3 to 5 centimeters above the carina, depending on the source that you're referring to. Heart borders, the hemodiaphragms, the costophrenic angles, those help to orient the film. Um, Symmetric lung markings extending to the periphery usually argue against a large pneumothorax. That's just a little tidbit. And then knowing the normal anatomy makes it easier to spot things that are abnormal. So, quality pitfalls in the transport environment. What happens if the patient can't take a deep breath or is rotated kind of funky on the backboard? There's always technical limitations that are part of the interpretation that you can't ignore. So depending on the rotation, it can make the mediastinum appear really wide. It can shift the trachea. If a patient has low lung volume, then the chest X-rays can mimic basilar opacities or enlarge the heart shadow. Um, Something to kind of keep out or keep a look for on patients with low tidal volumes. Portable AP films can exaggerate the heart size compared with upright. Supine films may make pleural effusions layer posteriorly and may hide small pneumothoraces. And external equipment, immobilization devices, motion artifact, all those things can obscure important findings. Let's take a look at some high yield imaging findings that most commonly change your transport management. All right, the most famous respiratory issue with regards to chest X-rays has to be a so a pneumothorax. So take a look at the image here. Um, we've got a deviation of the trachea to the right, which indicates a large pneumo, in this case on the left. So when you're looking at a chest X-ray, um, black is air and white is anything but air. So white could be anything from here's bone, it could be fluid, it could be consolidation like atelectasis, any number of things. So anytime you have um, pockets of black that kind of differ from what the rest of the film looks like, think along the lines of a pneumo. Here we've got a slight tracheal deviation with a pneumo here on the left, more pronounced down here where it's solid black. Notice that the cardiac silhouette is kind of cut off. It's a little more visible here, but still not what it should be. The cardiac silhouette should be all the way around like so. So here we've got free air roaming, and um, yeah, definitely indicative of a pneumo. But take a look at everything else though. So we've got rib expansion. We've got let's see, is that one, two, three, four, five, six, seven, eight, nine or so ribs expanded. Clavicles here. Um, it's always hard to see on these things, but actually I cannot even see the carina on this, which is okay. Um, but notice that the difference in the left lung versus the right. The right's got some parahilar streaking here, maybe even some air bronchograms. But the left is just air. So big old pneumo on the left. When you suspect a pneumo, don't don't go just based on the chest X-ray. Depending on the quality and the positioning, a pneumo can be kind of misleading, like falsely misleading. Um, but if a patient has respiratory distress, if they have rising pressures on the vent, if they're hypotensive, or if their breath sounds on auscultation are unilateral, so you hear more on one, versus the other, those can clue you in on whether or not what you see on the X-ray can kind of confirm that you suspect a pneumo. Um, Pneumos are very important to treat en route because a small pneumo can become a big pneumo in the blink of an eye, especially if they're on positive pressure ventilation, whether non-invasive or on a ventilator. If you see anything like this, anything that suggests a possible tension pneumothorax, those are very unstable patients that require immediate action. Um, there's a big risk with patients who are being transported via flight, and the need for definitive decompression or chest drainage um, before departure, if at all possible, if they have a tension pneumo. So as we look here, this one is I kind of like it because it's so messed up. Um, you can't even see where the trachea is deviated because there's so much going on. But everything is pushing over here to the left, and we have this giant pneumo on the right. So findings for a tension pneumo, it can include a large pneumo, doesn't have to be. The mediastinum or the trachea will shift away from the affected side. The hemidiaphragm, which is really hard to see on this one, is usually depressed or flat, and the rib spacing on the involved side. So this is the involved side, the pneumo side. Look how spread apart these are. Um, that's very indicative. Like this is a really bad tension pneumo. Don't delay decompressing in an unstable patient. Don't wait for a better image. If you get anything like this where you suspect a tension pneumo, err on the side of needle aspirating ASAP. Positive pressure during transport can really worsen trapped air, and also altitude on flights can really worsen trapped air. Um, the chest X-ray for a tension pneumo can support your diagnosis. It can confirm it even, but the actual emergency would be releasing that tension and air as soon as you can. Next, we've got pleural effusion and hemothorax. Um, if you have a trauma patient, think hemothorax or blood. In a medical patient, think heart failure, malignancy, renal failure, or infection. But in transport, the key question is how much reserve remains and whether drainage is needed before you have to move the patient. So, with the pleural effusion or any kind of fluid accumulation, the pleural fluid or the fluid itself often appears as a blunting of the costophrenic angle or a dependent opacity that meniscus upward on upright films. So if you take a look here, all of this white out down here, that should be visible lung. It is not. It is white. So it is a solid of some kind. So a fluid of some kind. And this one's pretty significant. Um, large pleural effusions or hemothoraces or any other kind of accumulating fluid that can really impede the patient's ability to oxygenate. It can really impede your ability to ventilate them if they are on a ventilator, and it can affect whether or not you can make it to your hospital destination or not. Um, always check or always take a look at the image and relate it to the patient and what you see. I mean, are they in some state of shock? Um, is a chest tube an option? And if not, what can you do to help release some of that fluid to allow that lung to better expand so they can oxygenate and ventilate. In patients who have pulmonary edema, that's a little trickier to diagnose on chest X-ray. Um, common clues include diffuse bilateral kind of fluffy opacities, vascular congestion, or like really visible but really interconnected vascular systems. To kind of take a look down here, where you can kind of see an example of that. Sometimes you've got an enlarged cardiac silhouette, sometimes not, but usually there's kind of a bat wing or a perihillard distribution uh, that that you can kind of see. Um, the biggest takeaway is that any kind of diffuse edema changes airway and oxygenation planning quickly. It's often correlated with shortness of breath, with crackles, auscultation. Um, blood pressure can be affected. Oxygen requirements go up. Um, these findings may drive CPAP or PEEP decisions, diuretic strategy, and closer transport monitoring. So basically, if you've got fluid on the lungs, in the case of pulmonary edema, the best thing to do, um, well, one is to push a diuretic, and two is to apply positive pressure in the form of either CPAP or BiPAP. You don't, if the patient's intubated, then that's one thing, but if they're not, they won't necessarily have to be intubated just based on the pulmonary edema finding. But positive pressure can really help to push the fluid off of the lungs. When you're looking at chest trauma patterns, note that chest X-rays often underestimate the actual level of trauma that the patient has. So always take a look at the assessment and not just the chest film. If they're in pain, if they're hypoxic, if they're developing crepitus, treat the physiology, not just the picture that you see. Because rib fractures in cases of trauma may be very subtle or even like undetectable on film. But when you do see it, they signal they signify a significant force and pain related to any to respiratory compromise. So these slides are a little tough to see, but here you can see let's see, rib 1, 2, 3, 4 here. So here it is. There's one, and then you've got this one here. So these should be connected. This guy is a major rib fracture. This one's a little blurrier than the one above it, but it is also a rib fracture. Always be on the lookout for a pneumo or pneumothorax or a hemothorax or a pulmonary contusion, subcutaneous emphysema, crepitus, where you can feel it kind of crunching when you palpate on the skin, because rib fractures are usually like the tip of the iceberg. You do not want that exposed rib point to puncture the lung at all. I mean that would make your life a lot more challenging. Flail chest, I know you've had that before. That's primarily a clinical diagnosis, but imaging can kind of confirm it with multiple adjacent rib fractures. And you should always anticipate it being harder to ventilate, harder for the patient to breathe, harder for them to splint, and additional thoracic injuries whenever you see or have confirmed rib fractures. Next, we'll talk about tubes, lines, and devices on chest X-rays. These are some of the most important transport relevant uses of chest X-rays, confirming whether the equipment in the patient is actually where it's supposed to be. Whenever you have a patient who is intubated, um, the ET2 position on the chest X-ray is very important, but so is capnography. Capnography is essential in making sure that the tube is in the right spot and stays in the right spot. Um, One thing to definitely keep in mind when you're looking at an endotracheal tube, tip on an X-ray for positioning, the positioning of the patient during the X-ray is really indicative of where that tube shows up on the film. So if the neck is flexed or extended, that can move where the tip is, and that really can impact your ability to determine whether or not it's in the right spot, especially if you're on the road. Over here, you can see this is kind of highlighted for ease of viewing. This is a similar kind of thing. So here's the endotracheal tube. Here's the tip. Here is the carina right there. And you can see where it bifurcates right there. This one's highlighted a little better. So here's a bifurcation to the left lung, bifurcation to the right, and then the ET tube right there. So endotracheal tubes should be roughly 3 to 5 centimeters above the carina in an adult when the head is in a neutral position. So all those things matter. Um, Chest X-rays are good for confirming placement. when you already know that you're in the right spot, um, based on your end tidal reading and the measurements on the ventilator and confirming chest rise and making sure that the breath sounds are equal and bilateral. Um, but still, always a good double check. A tube that's too low can enter the right mainstem, so right mainstem intubation. That's a problem because it makes it so that only one lung is ventilated, and then you're at risk of partial or complete lung collapse on the opposite side, usually the left side. A tube that's too high, so more than 5 centimeters above the carina, then you're kind of playing with fire, risking an accidental intubation during transport, especially because the patient's moving around a lot more than they would be if they were laying in a hospital bed. I did not have a good visual for this, but when you're looking at other tubes and lines, if they've got a feeding tube, the feeding or the enteric tube should be below the diaphragm into the stomach or even beyond that, depending on the intended placement. If you've got a tube that looks coiled in the esophagus or malpositioned in the airway, that can really increase the aspiration risk and overall, I guess, disdain for the patient. Um, Always check your chest tubes, any central lines, any pacing wires, all of those things before departure if you can, whenever imaging is available, if you can, to make sure that the patient is stable as they can be before you set off to your destination. Um, Fixing issues with tube placement and other line placements are a heck of a lot easier to fix before you're on the road, um, rather than trying to monkey with it while you're in the ambulance or in the cabin of the helicopter or plane. So trace every line and tube from the origin to the destination to make sure that they are in the spot that you want them to be. This slide here is pretty busy, obviously, and it's tough to see on a little computer screen. I'll make sure to get you this in a one pager. I did steal it from somewhere in England, but I really liked how it kind of broke everything down. So the this is a nice illustration of a normal looking chest x-ray with the diaphragms at their appropriate angles, the heart silhouette size that it should be, straight trachea, um, no obvious air in terms of pneumothoraces, no white markings for consolidation. So that's um, that's a good illustration. Um, this one here, let's see. So take a look at the different landmarks, the different markings, the different lines, um, and go through and as best you can with the size that you have, try to trace them. Trace the central venous catheter. Trace the dialysis catheter, the PAC, pulmonary artery catheter, chest tube, balloon pump, NG tube, all these different things. Um, so take a couple minutes and trace them because this is nice because it shows correct positioning of each. as well as incorrect positioning of each. Let's put all this together. You should have a simple process that you can use on your next clinical or your next transport shift to kind of ease the anxiety of reading a chest X-ray. Um, I'll be honest, most respiratory therapists hate looking at chest X-rays. They're not easy. One of the biggest takeaways is if you find something on the chest X-ray that looks off, if you can match it to the patient presentation on assessment, then you know that the odds are that that is the case, and you can take action as a result. Before you leave, so while you're at the hospital or wherever it is that you're stationary and have access to a chest X-ray, look for anything that might get worse during the transport, whether it's the shaking around, the length of time that the transport's going to be, if it's a flight transport, yeah, and take into consideration altitude um, issues, and then also positive pressure ventilation for sure. Um, I mean, if you have somebody who's got a suspected pneumo, then you're going to want to back off on the positive pressure until you can needle decompress and things like that. Um, if you notice anything that is off, try to correct what you can as soon as you can. So easier things like tube position, repositioning, retaping, resecuring the tube. In the event of needing any kind of needle aspiration or decompression or a chest tube, take care of that as soon as you can. Make sure you're looking at your oxygen strategy and increasing it as necessary to achieve a target SpO2. Make sure you've got suction on hand because you never know what's going to come up. Please give them pain meds because anytime you're dealing with this, the patients are in just a load of pain, and they have a plan for monitoring. So whether that be a standard monitor with blood pressure and pulse ox, whether it's end-tidal CO2, whatever you have at your disposal. And then if you go through the reading process in a structured manner, that's safer and better than just guessing. So airway, lungs, pleura, mediastinum, bones, devices, lines, and then you correct what you can um, clinically, based on all of those things. So let's take a look at a couple of examples, just real quick, and one quick slide. So let's say you've got an intubated patient who is right main stem intubated, um, and you have a left lung collapse because it wasn't detected. What do you do? Well, confirm that it's a right main stem, unsecure the tube, withdraw it so that it's in the proper position, and then re-secure it, and then confirm it if at all possible before you transport. Let's say you've got a trauma patient with a small pneumo, and you place them on positive pressure ventilation. Don't do that. If a patient has a pneumo, they should not be on positive pressure ventilation. If they are, and it's because the positive pressure ventilation caused the pneumo, then you need to back off on the pressure as much as physically possible. reassess whether or not you can needle aspirate or decompress or insert a chest tube, um, or anything before you continue, because if somebody has a pneumo and they're on a vent with positive pressure, it will only get worse. Um, Flash pulmonary edema, very common, with diffuse bilateral opacities. Um, Usually, those folks need some serious positive pressure in the form of PEEP and a lot of oxygen, to overcome all of the VQ mismatch that pulmonary edema and other fluid issues can cause. A widened mediastinum, especially after a high-speed deceleration, after braking or landing if you're in air. Um, though that's a bad thing. Treat that as a potential time critical vascular injury, and get them to their destination as quickly as possible. And to wrap up, portable chest x-rays are not perfect by any stretch, but they do offer a lot of value in transport medicine when you read them systematically. Um, Please understand the life threats. So, pneumothorax, tension pneumo, big time fluid collections, pulmonary edema, hemothorax, things like that. And then whether or not the tubes, endotracheal or otherwise, are in the correct spot. Um, the technical quality matters, especially with AP portable film, so don't use it as like the be all end all. And imaging should only change your care of the patient only after you connect it to the patient in front of you. Um, use it as a guide, as a key. Remember that black is air, white is consolidation and or fluid of some kind, and go from there.